Chitrakala, you can play the lamplight. Suman?
Yes, Chitra. So a very good evening to all the doctors and participants. I Shumon on behalf of Shield Healthcare, welcoming you all in KSUGS, that is Karnataka College of Obstetricians and Gynecologists, presents an international academic program on gestational diabetes mellitus, long-term consequences for the mother and child. And our guest speaker is Dr. Professor L. Chainer, sir. So first, I would like to introduce our session chair, that is Dr. Hema Madam. And although you know Hema Ma'am very well, but it's my formal responsibility to introduce Ma'am. Ma'am is the CEO and Chairman, Artist, Chair of Women Healthcare Committee at FIGO. Madam is the Dean KCOG, President DIPSI, Vice President AHPI, and Madam was the first President of FOXI in the year 2013, and first Vice Chair for FIGO PNCD Committee, and advocate for delivering quality healthcare convener in Manata, an opinion leader and an influencer for social and legal issues related to women's health. And in terms of academic distinctions, awards, and recognitions, Madam won the FIGO Women Achievers Award in the year 2015, Global Asian of the Year 2018, CME Excellence Award for Artist, Next Brands Award for Artist for her, and CSR Times Awards or CSR Impact Award for Divagar Service Trust. So apart from that, many other awards also, but I am just briefing few of it. So thank you very much, Madam, for organizing a nice session with Dr. Professor L. Chainer, sir. And over to you, ma'am, for further proceedings. Thank you very much.
Namaskar, and thank you very much, Suman, for that very generous introduction. We look forward for the last Thursday of every month. The team Kasoga and the team KCOG, which is the Karnataka College of ONG, brings to our beloved delegates an international speaker series. And today we have the distinguished presence of Professor E.L. Scheiner, who is not only an expert in the subject with a vast experience, but also my very beloved friend. So before we formally introduce E.L., I would like Dr. Bharti Rajshekar, who is the Honorary Secretary General of the Kasoga, to kindly make the opening remarks before we move on to the session. Bharti?
Very good evening to all of our fellow Kasogians and Dr. Professor E.L. Scheiner for having been spending his precious time with us today evening. At the outset, I would like to say we are happy that we are celebrating our 74th Republic Day, and on this day, we have a very important topic which Dr. E.L. will be speaking to us. We know that India is sitting on a time bomb of diabetes mellitus, but along with that, it is alarming that the incidence of gestational diabetes is also like a tsunami invading into our country. And unless we do start managing gestational diabetes in an effective way, we are going to see an enormous rise in the incidence of not only diabetes mellitus, but other metabolic disorders also. And I think Dr. Hema on this evening in the KCOG program, she has taken up a very, very important topic which all of us need to address. And over to you, Dr. Hema, without wasting much time, for Dr. E.L. to enlighten us of how we could effectively manage gestational diabetes mellitus and reduce the incidence of metabolic disorders around the world. Thank you very much.
Thank you, Bharti. Welcome to all the delegates on behalf of Team Artist, Team Kasoga, Team KCOG, and of course, we are ever grateful to the tech support lent by the Shield Healthcare. So when I asked for ELCB, I had a whole book because he has published so many papers in so many international journals that runs more than 75 pages to be precise. So I went on scrolling down and I said, how I'm to introduce him. So in whichever manner I introduce, I will still fall short of many things that I'm proud of what EL has achieved and accomplished. He hails from Israel, Tel Aviv, where we have been witness to the very exciting scientific celebrations that have happened through our associates through the PNCD committee. So Professor Eyal Scheiner, who is the guest speaker for today, as Bharti said, that once the patient who has been diagnosed as hyperglycemia in pregnancy goes home, we cannot presume that all is well, because both for her child and the mother, we need care forever after. So Eyal, who is the greatest expertise in this topic, having produced the recommendations and papers for the international organization FIGO as well, which we want to translate into reality. And what better an opportunity we could have than hearing from the expert himself. He's the chairman of Soroka Medical Center's Obstetrics and Gynecology B Department and Vice Dean for Academic Promotion at the Ben-Gurion University Medical Sciences Faculty of Ultrasound Fellowship at the Rush University Medical Center at Chicago. Previously, he served as the Deputy Director General of the hospital and the Head of Residency Program of the hospital. Following his residency, he earned his doctorate in epidemiology and public health. His PhD study and ultrasound fellowship at Rush University Medical Center in Chicago was supported by a grant from the Fulbright Visiting Scholar Program of the United States. Professor Eyal Scheiner, as I told you, has published extensively in the area of perinatal epidemiology, more than 620 peer-reviewed articles and book chapters, and editor of more than 11 books. And his knowledge share will be extremely important as a value add for the programs that we would have in the deliberations this evening. So may I once again, on behalf of all of you, appreciate his presence and participation and his consent to very readily agree to deliberate on this very important topic. So once again, my humble welcome to Professor Eyal Scheiner. Over to you, Eyal.
Wow, thank you so much. From all the titles, the best is a friend of Chema, my favorite partner in the FIGO. And thank you so much for inviting me for the opportunity to present our study. If the internet connection is not stable, just let me know and I'll pass to another computer. And let's start screening. Okay, can you see the share screen?
Yeah, perfect, yeah.
Okay, so again, thanks again. It's very excited for me. I have to say that I've been in India several times. Each time is more fascinating than the other. It's my favorite place on earth. I just love the people. First of all, I love everything: the country, the sea, the beach. It's an amazing country for me. The taste, the sounds, the colors. So you're blessed living in India. And I will discuss the long-term morbidity of the mother and offspring in cases of gestational diabetes mellitus. And it's very important for me, this lecture, because when I started residency, I was told that gestational diabetes, it's a gestational disease, meaning gestation pass, the disease passes. And that was in 1996, I think, when I just started residency. And then few years later, we were all familiar with the fact that gestational diabetes is not an overt diabetes of pregnancy, and we were familiar with the fact that more than 50% of the patients with diabetes will develop diabetes later in life. So we wanted to expand it not only to diabetes, but to other cardiovascular morbidity of the mother, and then we wanted to expand it to the baby. We all know that GDM, diabetes is in epidemiology, is epidemic. Diabetes and obesity become more and more familiar and more common, unfortunately, in the Western world, in all over the world, actually. And in the previous century, we were discussing HIV. In this century, we are discussing obesity and diabetes. The obesity, we call it like the combination of the two. And the burden of the disease is expanding at an alarming rate, particularly in the developing world. Approximately 14% of pregnancy worldwide are complicated by diabetes, 90% in low or middle income countries. We are seeing it more and more, and unfortunately, we will keep on seeing it more and more. And we see it during pregnancy. And I'll come back to this important slide because pregnancy is a window of opportunity. Pregnancy, we don't like to go to doctors. And when you go to the doctors, in most population, you go to the doctors when you're already sick. And in pregnancy, it's in your hand. You have the opportunity to catch a healthy patient and to target patient at risk for long-term, to adhere to long-term recommendations. And in this lecture, as I said, I will discuss the implication of diabetes on both compartments, on both issues, the mother and the child. And I will present mostly the works that we did in our medical center. It's local patriotism, but it reflects other countries as well. And why can we study this? I mean, in my hospital, how could we do all those studies? So first of all, we have a great database. Every patient that go into labor and delivery, the attending physician fills a chart during the labor and delivery. During labor and after labor, has to fill anything that's going on with the patient. He has a full list of complications that you have to mark. It's actually ICD-9 codes. That's what we use meanwhile. And after delivery, we have 4 secretaries that are working with us. Those 4 secretaries are working with us for years. They started before I started. So from 1996, those are the same secretaries. We are very good friends. And they pass throughout the charts. And if a doctor didn't feel anything correct, they return the chart to his file for repairment. For instance, if the GCT test and the glucose tolerance test was abnormal and they didn't mark that the patient has diabetes, she returns it to my drawer for me to fill the chart properly. It's like, to make sure that the charts are well adherent to and well treated. And we have a very busy labor and delivery room, so it helps us that all our patients are actually our precious patients, but they are also part of our statistical database. And as I said, we have the busiest labor and delivery in Israel. We are having, I don't know, concerning India, but in the Middle East, it's a very busy labor and delivery. We have 17,000 deliveries a year. It's the busiest medical center in Israel. And in our database, we had, when we did those studies, we had 250,000 patients. Now we have 350,000 patients. This is the Soroka University Medical Center, and it has another benefit. It's the only hospital in the Negev, in the southern part of Israel. Only one hospital serves the entire population of more than 1 million people, residents. Unlike the center of Israel, which is a very popular place, Tel Aviv, for instance, only in Tel Aviv in the center, in the area of the central Israel, we have like 5 hospitals. In the southern part of Israel, 1 hospital. It's a huge hospital. It has more than 1,000 beds. And again, the busiest labor and delivery room. And thus we were able to evaluate exposure, which now the exposure is GDM, and the outcome, it's hospitalization. And importantly, because we have only 1 hospital, the patient has to come to the same hospital if they were sick, and same for the babies, because it's 1 hospital that serves the entire population. So unless the people left the Negev area, left the southern part of Israel, if they need hospitalization or any treatment with the clinics, they had to come to the same hospital. And again, this is unlike Tel Aviv, because you can choose your doctor for 1 hospital and then go after delivery to another hospital and then go to the 3rd hospital, etc. We combined the several databases. First of all, we combined the computerized perinatal database of the mother with the computerized hospitalization database of the Soroka. It wasn't easy, but it worked out. The problematic issue was to compare the data to the baby, because the baby in Israel, everyone has identical number, ID number. To take the data, the ID number of the baby from the mother, it was a very complicated process, like ant work. This is why I'm showing you the ants that are passing through the screen. And but we managed to do it. So we had a combination of the data of the patient when they were admitted to labor and delivery. And then we could combine it to the hospitalization and clinic and outpatient clinic of the Soroka University Medical Center for the mother, as well as for the babies, for the children. And we were able to follow up the women until the year until the day of the actual when you collected the data of the actual publication. And for the babies, we could the follow up until 18 years of age, because then after 18 years of age, there are no more in the pediatric database. Okay, so speaking about diabetes, I want to concentrate in the 2 compartments. One of them is the mother, and the second is the baby. And the most important patient for us as obstetrician is the mother. So let's start with the mother. And speaking about the mother, I want to talk about several complications. Whether or not the mother with diabetes during pregnancy, gestational diabetes mellitus, is at high risk for cardiovascular complications, for renal complications, for ophthalmic complications, and for oncological complications. And let's start with the most well-known, well-established linkage between gestational diabetes mellitus, overt diabetes, and cardiovascular disease. So we're starting with the cardiovascular system, and this study was published in the Heart Journal, and it evaluated the association between gestational diabetes mellitus and long-term maternal cardiovascular morbidity. And it's very important to establish that throughout all our studies, we were focusing on gestational diabetes, because overt diabetes, insulin-dependent diabetes, type 2 diabetes are well connected to many complications. They were out of the scope of our study. They were excluded from the study. We focused purely on gestational diabetes mellitus. Okay, so this is the Soroka University Medical Center. This is the actual Saban Birth and Maternity Center, which all our parturients are hospitalized. And in this study, we took deliveries until 1998, and the exposure was GDM. The outcome was hospitalization for any cardiovascular morbidity. Obviously, we excluded pre-gestational diabetes. We also excluded multiple gestation because the whole pathophysiology is different. We know that twins is a risk factor for diabetes, and we know that the load of the heart and all the systems is higher in twins, so we wanted to exclude them. And obviously, we excluded patients with known cardiovascular or renal diseases. The statistical analysis included survival tests, because we wanted to know not only at the end if they had higher rates of complication, we wanted to see how they act throughout the period. So that's why we We did the survival analysis. We evaluate Kaplan-Meier curves, which are survival curves. And in order to control for confounders, we constructed Cox proportional hazard models, which are multivariate analysis models that control for the length of exposure, because we know that a patient who delivered 1 year before may have less chances to have a cardiovascular disease compared to patient who deliver at the beginning of the study period. So we needed to control for the length of exposure from the first exposure, which is GDM, to the actual being defined as cardiovascular disease. In this study, we had 1,500 women. The rate of diabetes, GDM, in this population was 10%. Just a minute, I don't know why it's jumping. The rate of GDM was 10% in our population, and the rate of cardiovascular, the crude cardiovascular morbidity rate was 9% in the GDM patient as compared to 3% in the no GDM patient. Now, think about it. We are speaking about young patients with gestational diabetes mellitus, and we are observing their cardiovascular morbidity with a length of exposure of 11 years. When I first conducted the study, I didn't believe that I will see any differences in such a short time period. I said, okay, we have like the mean exposure was 11 years, we had the exposure up to 20 years. What are the chances that I will see any cardiovascular morbidity? But think about it. 3 times higher risk for cardiovascular morbidity among GDM patients. It's unbelievable. And this is the total cardiovascular hospitalization. You can see here, we divided it to non-invasive cardiac diagnostic procedure, to invasive procedure, to simple cardiovascular events, to complex cardiovascular event, and even to death during hospitalization. And the crude rate was 9% versus 3%. And when we controlled for confounders, you can see here the adjusted odds ratio, because obviously we needed to control for many confounders. And even after we controlled for confounders such as maternal age, such as obesity, such as smoking, the risk was 2 times higher. If the patient had GDM, she is at significant risk for cardiovascular morbidity. And it was also significant for non-invasive cardiac procedures and for simple cardiovascular tests. This is the survival analysis, because as I said, it's more interesting to see how patient behaved throughout the study period and not the crude, the total. As you can see here, this is a survival function, this is the log of survival, and this is the study duration. And patient with GDM acted differently as compared to patient without GDM. Throughout all the study period, day by day, year by year, patient with GDM had lower survival. Survival, I mean not mortality, but disease, cardiovascular disease. So they had lower survival as compared to patient without diabetes mellitus. And the p-value was obviously significant, 0.001. You can see here the multivariate analysis, the Cox proportional hazard model, while we control for obesity and preeclampsia. Both are well-established risk factors for cardiovascular morbidity. Preeclampsia was the first disease that the model of the pregnancy exposure and the long-term complication was based on. And as you can see, even while we control for obesity and preeclampsia, patient with gestational diabetes mellitus has 2.6 times higher risk to develop cardiovascular morbidity as compared to patient without diabetes. Interestingly, obesity and preeclampsia were noted as risk factors, but very interestingly, the risk was lower as compared to the risk of GDM. The obesity increased the risk 2.5 times and preeclampsia 2.4 times. So regarding cardiovascular disease, undoubtedly exposure to gestational diabetes mellitus poses a significant risk for long-term cardiovascular disease. We didn't end our analysis in cardiovascular disease. We wanted to concentrate on other diseases such as renal, ophthalmic, and oncologic. So what's going on with renal disease? Here, the rate of renal disease, the rates are lower as compared to the rates of cardiovascular disease. And if we were speaking of cardiovascular disease, it is noteworthy to mention that the risk was 10%. 10% risk to develop cardiovascular disease. Here, the rates were lower, but still significant. If you are looking at renal morbidity, we had patients with GDM as compared to patients without GDM, and the risk for renal morbidity was 2.3 times higher if the patient was exposed to GDM as compared to patients who were not exposed to GDM. You can see here the survival analysis. Here we show it not as survival, but as risk, because sometimes it's easier to show those graphs. And you can see the exposure time, and here is the risk. And you see that the risk for patients with GDM throughout the period to develop renal morbidity was significantly higher as compared to patients without GDM. And the cumulative risk for renal disease differ if the patient had more than one episode of GDM, meaning if she had GDM in several pregnancies, the risk increased in a linear manner. This is the risk for a patient without GDM to be hospitalized because of renal disease, 0.1%. If she had at least once GDM, it jumped two times higher. And if she had more than 2 episodes, the risk again jumped, and it was 0.1, then 0.2, then 0.4. What about ophthalmic disease? Ophthalmic disease, again, it's a very rare disease, and it's very linked to diabetes, to severe diabetes. But even when dealing with gestational diabetes, again, only gestational diabetes mellitus, not overt diabetes during pregnancy, not insulin dependent. Patient who had gestational diabetes mellitus, the total ophthalmic complications were 0.6, mean 3 times higher as compared to patient without GDM in pregnancy. And again, the risk was statistically significant. We can see 0.6 versus 0.2. The odds ratio was 3, and the confidence interval did not involve 1, meaning that it reached statistical significance. Here we can see the multivariate analysis, the COX, and even while we controlled for parity, obesity, preeclampsia, and maternal age and index pregnancy, the risk was 2 times higher. And we can see the Kaplan-Meier curve. And in this curve, it's very interesting to see that this is the risk for patient without GDM. If the patient had GDM, this is the risk throughout the years. And this graph show you the risk of whether or not the patient had combination of GDM and preeclampsia. And if we had those 2 diseases together during pregnancy, the risk for ophthalmic diseases jumped significantly. So again, GDM is a risk factor for long-term ophthalmic disease. And lastly, speaking about the mother, I'll say a few words about oncological diseases. Yes, oncological diseases and gestational diabetes mellitus. We're obstetricians, so we focus on gynecologic malignancy. We focused on ovary, uterine, cervix, and breast. We had about 10,000 patients with GDM, which were compared to almost 100,000 patients without GDM. And the results were shocking for us. We were very amused by the results. When we conducted the study, I told my partners that we will be underpowered to say anything about the results, because we are speaking about oncological disease, not about cardiovascular disease. And the results were very amazing because the risk was significantly higher. If we combine all the obstetrical, gynecological malignancy, the risk was 1.7% among patients with GDM versus 1% in patients without GDM. The odds ratio was 1.8 times higher, meaning if the patient had gestational diabetes mellitus, the risk was 1.8 times higher to develop oncological disease. And as you can see, the risk was significant for breast cancer. The risk for breast cancer was 2 times higher, and the risk for uterine cancer was 2 times higher as compared to patients without GDM. You can see here the Kaplan-Meier curve. And throughout the study period, those are the patients with GDM, and those are the patients without GDM. The cool thing about Kaplan-Meier is that you don't need the p-value, you can just see it in your hands, because if the figures parallel together, it won't be significant. But if you see two different figures, then it means that you probably have a significant p-value, as it was here. And even when we control for confounders such as fertility treatments, maternal age, and parity, and why fertility treatments? Because the reviewer insisted that we control for fertility treatments because he was concerned regarding the association between fertility treatments and ovarian cancer. And even when we controlled for fertility treatments, maternal age, and parity, GDM was noted as an independent risk factor for long-term gynecological oncological malignancy. Okay, so this is the mother, and now what about the baby? So let's talk about the babies. Speaking of the baby, I want to cover several diseases: neurological disease, endocrine disease, cardiovascular disease, and ophthalmic disease. And here, luckily enough, the rates of the diseases are very low, unlike the cardiovascular disease. Again, the 10%, I'll say it again and again, the rates are low, but as you will see in a few minutes, low but significant. So the first study, this study was published in the American Journal of Obstetrics and Gynecology. It was an oral presentation in the SMFM, Society of Maternal and Fetal Medicine. And here we evaluated prenatal exposure to gestational diabetes mellitus as an independent risk factor for long-term neuropsychiatric morbidity of the offspring. We hypothesized whether or not imbalanced glucose level could have an effect on the brain. And we wanted to focus on several areas of the brain, like the cortex for epilepsy, the midbrain for CP, the limbic system, autistic spectrum disorders, and the brainstem, meaning obstructive sleep apnea, which in babies, you are well familiar with the fact that unlike adults, which is a respiratory disease, in children, it's a neurological disease. So in this analysis, we had more than 200,000 deliveries. 95% did not have GDM, 4% had GDMA1, and 1% were complicated by GDMA2. Let's see the study population. In those studies, we subdivided it to GDMA1 and to GDMA2. GDMA1, which were well controlled by diet and physical activity, and GDMA2, which were not, and they needed prescriptions of insulin or oral hypoglycemic agents. So as expected, maternal age differed between the group because patients with GDM tended to be older as compared to patients without GDM, and it was statistically significant, meaning that we will need to control for maternal age. Birth order differed as well. We can see that GDM patients tended to be more multiparous as compared to patients without GDM. And if we will take a look about nulliparity, it was very low in GDMA2 nulliparity, unlike multiparity, which was higher. Now let's dip into the results. Those are the results of the jury. The risk for autistic spectrum disorder was significantly higher among patients with GDM as compared to patients without GDM. The risk for eating disorder was statistically higher among patients with GDM, and the risk for obstructive sleep apnea was significantly higher among newborns born to GDM patients. And we can see that there is a linear association between the complication of the disease and the risk for neurological morbidity. For instance, autistic spectrum disorder, luckily enough, it's a very rare issue. But you can see that the risk was 0.01% if the patient did not have GDM, the risk for the offspring to have autistic spectrum disorder. It jumped twice to 0.02 if she had GDM-A1 and 0.07 if she had GDM-A2. And obstructive sleep apnea jumped from 0.6 to 1% if the patient had GDM-A2. The other complication that we evaluated, epilepsy and CP, did not differ between the groups. But when we were measuring the total neurological morbidity, the total was higher in patients with diabetic, and it was higher in patients with uncomplicated diabetes, meaning that if the patient with GDM offspring that was born to a patient with GDM was at a significant risk to develop neurological morbidity, and the risk was higher if the baby had GDM-A2 as compared to GDM-A1. And here you see the Kaplan-Meier curve, and you can see three colors. In blue, no GDM, in green, GDM-A1, and in beige, GDM-A2, meaning that there's a dose-response association between the severity of the disease and the outcome, the neurological morbidity of the newborn. If the disease is not complicated, the risk for your baby is higher as compared to a complicated disease, meaning that it's in our hand. Just think about the long-term implication. You have to be well controlled because it's not only for you, it's for your baby as well. And those are the results of the Cox proportional hazard model. The model controlled for maternal age because it differs significantly, and it's a very important issue. And obviously, it controlled for gestational age because we know that preterm is a major risk factor for neurological morbidity. And it also controlled for parity because we had differences in the parity. And as you can see, both GDM-A1 and GDM-A2 were both significant risk factor for long-term neurological morbidity of the offspring. And the risk was 1.2 times higher if she had well-controlled GDM, meaning GDM-A1, and the risk was 1.4 times higher if she had uncontrolled GDM, meaning GDM-A2. What about endocrine disease? This study was published in Diabetic Research and Clinical Practice. We evaluated neurological morbidity in patients with no GDM, GDM-A1, and GDM-A2. And again, we can see the dose-response association. Now, again, we're speaking about the offspring risk for endocrine morbidity. And as you can see, the risk for endocrine morbidity of the offspring was 4.5% in the comparison group. It jumped to 8% if the patient had GDM-A1, and it jumped to 14% if the patient had GDM-A2. And you can see that the major issue was diabetes. And here we are speaking mostly about insulin-dependent diabetes mellitus. Think about it. The GDM, the mother has GDM, and the baby is at significant risk for diabetes and for overweight and obesity. Both entities were found as statistically significant issues if you are dealing with the offspring of the diabetic mother. And this is the Kaplan-Meier curve. Again, you can see dose-response association. This is the risk for endocrine morbidity, which is very low if you were not exposed to diabetes. This is the risk if you were exposed to GDM-A1 in green, and again in beige. This is the risk if you were exposed to GDM-A2. Again, a dose-response association. And again, we conducted a multivariate Cox analysis. We controlled for the same confounders, maternal age, obesity, birth weight. Here we controlled for birth weight because there's a clear association between macrosomia and obesity of the offspring. And again, even while we controlled for all those confounders, the risk for endocrine morbidity was 2 times higher if you were exposed to GDM-A1, and the risk for your offspring to have endocrine morbidity if you're exposed to uncontrolled diabetes, meaning GDM-A2, is almost 3 times higher. So diabetes, endocrine disease of the offspring, a very significant association. What about cardiovascular morbidity? Acta Diabetological, we conducted a study. We evaluated offspring cardiovascular morbidity of patients with GDM A2, GDM A1, and no GDM. And again, a dose response association, the significant association. I have to say that because dealing with cardiovascular morbidity in offspring is a very rare issue. And again, we were very surprised by this study. We didn't believe that we will reach statistical significance. And take a look at this, 0.3% risk for cardiovascular morbidity for patients who were not exposed to GDM. And if they were exposed to GDM-A1, it reached 1%, 0.5% if they were exposed to GDM-A2. And we can see that we evaluate several diseases like structural vulva, arrhythmia, and the significant issues were structural vulva and arrhythmia. The other did not reach statistical significance. And when we control for confounders, again, GDM was noted as an independent risk factor for long-term cardiovascular morbidity. The numbers of the GDM-A2 were too low, so it didn't reach this statistical significance, but when you combined both diabetes, the statistical significance was very remarkable. And lastly, about the baby, ophthalmic disease. Again, if ophthalmic disease is rare among mothers, among babies is even more rare. And but interestingly enough, we found the GDM. Here we found the significance only for GDM A2 for uncontrolled GDM, which is in beige. Only patients with the GDM A2, their babies were at significant risk for ophthalmic morbidity. Okay, so what did we learn? We learned that GDM is a problematic issue. We learned that GDM is not a gestational disease, and we learned that GDM is a risk factor for morbidities, several morbidities of the mother and several morbidities of the child. And again, pregnancy is a window of opportunity. It's in our hand because this is the cycle. This is the patient. When do we go to see doctors? When we are toddlers, because we need to go to the doctors because we need to be immunized, stuff like that. Then we go when we are pregnant, and then we'll go when we already have diseases. So pregnancy is a window of opportunity. We have the chance to consult healthy women regarding their future. And the pregnancy is a stress test. And in this, it enables us to see which patient we should be under our focus. GDM is an independent risk factor for long-term morbidity of the mother and child. Surveillance is required following GDM for early detection of long-term morbidities of the mother and child. And we know that the American Heart Association published guidelines regarding patients at risk for, it started at 2011. Who is at risk for cardiovascular disease? Let me increase it in size. And they were speaking in 2011 that pregnancy complications should be our focus. And which kind of complications? Let me increase it in size. Again, GDM. Just before the corona, I was lucky enough to join a precious group of amazing people. It was in Italy. One day before the corona. You can see here my favorite friend from the group. I hope you're all familiar with her, my beloved friend Chema. And I think this was our first meeting, love from first sight. And our team involved many doctors throughout all over the world. There were gynecologists, cardiologists, I don't know, hypertensive experts, diabetes experts, GYN from all over the world, and we publish the figure supplementation regarding the post-pregnancy initiative, the long-term implications of pregnancy complication. And GDM was certainly one of the focus of these recommendations. And our recommendations were very easy. We recommended that the following measurements should be implanted at 6 to 12 weeks after birth and periodically thereafter in a pregnancy complicated by GDM regardless of the criteria used to diagnose GDM. And what did we suggest to do? Very easy things: history and physical examination, blood pressure measurements, and screening for diabetes. And again, we all know that GTT is the best, but we said, okay, if you can do it, just do the fasting glucose or hemoglobin A1C. If you can do the 75-gram GTT, it's recommended. But if you can't, just do something. We want the patient to be at a follow-up, at a regular follow-up, for a yearly follow-up of very common things. And that's all. I mean, guys, just put them in your focus, because it's the best secondary prevention that we can offer our patients. This is I'm really into this topic of the long-term impact of medical complications. This is my 10th book that was focused only on the issues of the long-term impact of medical complication. It has 18 chapters, half divided to the mother and half to the child. And just for me, I'm just trying to spread the knowledge about the long-term implications of pregnancy complication. And I would like to thank you all very much for your kind attention. It was a very great opportunity for me to see all my friends. And I hope the next issue will be frontal, not through the web.
Thank you so much, Eyal. This was just mind-blowing. That's what Bharti has been writing in the chat box as well. And, the overwhelming data, the numbers and the quality of the research that you've done is just amazing. I mean, it's very, very difficult for us to digest that so much work could have ever been done. So for all the hundreds of delegates who are watching this, they have been posing many, many little questions in their own merit. But first, I will let Bharti go ahead and ask her questions, and then I will get on to the audience questions. Thank you, Eyal, again. Bharti?
Thank you, Hema. And Dr. Eyal, I very well endorse your view at love at first sight. I think anybody who sees Hema falls in love with her immediately. And you are not an exception to this. Okay. We have a wonderful. Yes, sir. Yes. Yes, Doc. And she is somebody with a vision. And of course, we would like to do something, at least a small fraction of what you people have done in Israel. It is amazing that have this database, you following up the children of GDM, mothers, and as well as the women of GDM, going on to the of about 14 to 15 years post GDM. You have done the studies to find out the long-term consequences, and indeed it is very disheartening to see that most of these women are at twice the risk and thrice the risk of all sorts of metabolic disorders as well as oncological complications. So I have a question, Dr. Eyal. Is there any difference that you have noted in the GDM women who have been well controlled during pregnancy? And because we see a lot of women who do not have a good control of their GDM, and do you see a statistical difference in the consequences when they are well controlled, the incidence, could it be brought down, the long-term consequences?
First of all, the risk, if the patient was exposed to GDM, if the patient had GDM, her risk was higher, period. But the risk was significantly higher for the not well controlled. If she was well controlled, the risk was lower. It's always a dose response association, meaning that you should be. We don't know if it's regarding the baby, we think that it's the exposure to a hyperglycemic area that was the issue. But for the long-term complication, we are all familiar with the fact that the patients who are not well controlled during pregnancy will not be well controlled after pregnancy. Those are the patients that less likely to adhere to our recommendation for diet and physical activity. In some patients, when I speak about physical activity, they look at me like this. I mean, come on, what are you talking about? I was amazed to know that if you show data regarding the newborns, it's sometimes more helpful than data regarding the mothers themselves. It's like they care for the babies more than they care for themselves. And when we published the neurological article in the American Journal, it was it made a lot of noise in Israel. And I mean, for us, it was a good noise because it's like something that I want to spread. The point that GDM is a risk not during gestation. And many patients just, you're thinking about your baby, neurological morbidity, even though the numbers were so low, they were still at risk. Because for me, the most important issue, and that's why we focus on the FIGO guidelines regarding cardiovascular disease, because this is 10%. Guys, 10% with the mean exposure of 11 years. What is 11 years? It's like this, time flies when you're having fun. So it's interesting that sometimes you have to show them the whole package. And if you're not controlled, if you're well controlled, the risk is lower. If several morbidities did not reach statistical significance for well-controlled patient and only for the non-controlled patient. For instance, the ophthalmic morbidity of the offspring, no association was noted. The well-controlled behaves similarly as the healthy population. So you should be well-controlled not only for you, but for your baby as well.
Yeah. Thank you, Dr. Eyal. And as you said, I think we also play this small tagline when we speak to GDM mothers, telling them that their baby is going to get affected. And the first question they do ask us is, I have diabetes, will my baby have the diabetes or consequences? And when we tell them that there are long-term consequences for them as well as the child, I think they are more concerned about the control. And I think this is what we obstetricians in India also should try to talk to them and tell them that your baby also can suffer. So they are more concerned about controlling their hyperglycemic status. Thank you, Dr.
They call it in Israel the magic weapon.
After
there was a big noise, because, for instance, it's autism in Israel is the scariest thing now. You cannot say anything about autism because Down syndrome you can detect. Autism is something that you cannot detect. And when the study was spread, the point was autism, which is like, the risk was 1% if she was uncontrolled, 0. Nothing if it was so low, but still, but I said, okay, if it helps, this is our magical weapon. So control yourself.
Yeah, true, sir. True.
Yeah. So here there's another important question here, because India is swinging from undernutrition to obesity, where about 37% rise in obesity. So the question that they have asked is, the well-controlled but lean as against well-controlled with obese, will that subset make any difference? Will obesity also be a important risk factor in enhancing some of these long-term complications?
It's a great question, because we did, first of all, diabetes is a risk factor whether or not you are lean or obese. But if you're obese, the additional risk is jumping higher. We did several complications, mathematical, we spread the population to GDM and obesity, GDM, hypertension and obesity, and the risk was enormous. If you had the combination of GDM, obesity, and hypertensive disorder, your risk for cardiovascular disease for you and the risk for the baby jump linearly. So it's better to be lean and obese than to be obese. It's better to be lean and with GDM than to be obese and GDM, because you combine both risk factors for most of the morbidities. And the same is if you have the combination of hypertensive disorders, which is like the three most important metabolic syndrome issues. And if you put them together, your risk is very high.
Yeah. And also there's another question about the compliance of the mothers themselves for a long-term postpartum follow-up. Since you have such a large amount of data, what is the system in the hospital to recall? Because, you said that they may not pay so much attention to their own health, but when it's the child, they will come back and forth again and again. But the women who are well-controlled or otherwise, when they're out of sight, out of mind, or do they actually come back at regular intervals for a long-term care?
Well, we see when they are sick, they come to the hospital. When they are sick, they come to the clinics of the hospital. When they are healthy, they don't. And we have a missing data regarding patients who went out of the area, which is very low because immigration is positive to the area, not negative, basically. But healthy people don't go to doctors mostly. We recommend for all patients. This is a very important thing that we started to do it only after the FIGO guidelines were spread.
Yeah.
And after the FIGO guidelines were spread, in our medical center, we invite all patients with GDM. We write it down in the chart. It's part, you have a diagnosis of GDM, then the file as a recommendation. Same for hypertensive disorders, by the way. If she had preeclampsia, we recommend her to go 6 to 12 weeks to her doctors. For preeclampsia, we recommend the same as GDM, interestingly, yes. But if we recommend to go to physical examination, to blood pressure measurement, and if she's obese, we recommend to do the GTT screening, even though she had only preeclampsia without GDM. Okay. And for GDM patients, we put the FIGO guidelines because they are very easy. When we sat down regarding the guidelines with Chema, the cardiologists said, maybe we'll recommend echo, to do echo test to all patients after GDM. I said, I don't have enough appointments to do echo. Let's start with the simple thing. I want them to be under attention, to be in the focus of your attention. And so that's what those were our recommendations. Last year, I took a medical student and we wanted to know how many people actually adhere to the recommendation that we give them to go to routine checkup 6 to 12 weeks postpartum. Unfortunately, it was less, it was 50%. It was not enough. And we did the consultation with the family physician. I did the conference with all the family doctors in the southern part of Israel. So I'm trying to push further the awareness to those guidelines.
Yeah, so I think this is a very important take-home point, because I too think that after we established the FIGO guidelines, it was a little more with conviction. We could tell them that, yes, you definitely need to come because there is the problem lying out there. And then the telephonic recalls, or wherever it's possible, at least we've started doing, so that slowly it will sensitize, populate, and get into larger numbers, because everybody in the country have started becoming a little more serious about the annual checkups for those with hypertensive disorders in pregnancy and those with hyperglycemia in pregnancy. That's for sure. And the well women healthcare, what we're saying, that the recommendations age-wise, when we say the preventive healthcare, this forms a very important prong of that whole armamentarium of the checkup, because the other comorbidities, which we feel as OBGYNs, just let's get over with the pregnancy and just let's wash our hands off, because, it's too much. The other major organs, if we have to pay attention to. So that's how the mindset was, but it's slowly, steadily changing for the benefit of the health of the next generation and also our new mothers who are dealing with this. One last question, Eyal. The non-invasive continuous glucose monitoring, some of the fantastic devices are being now, spoken about by Professor Hood and others emerging out of your country. And how much do you think the kind of regulatory control of the sugars with home monitoring, with continual monitoring, with non-invasive tests, where semi-skilled people can use it extensively to reach the last mile in low middle income countries? How do you see that bridging the gap between the high income and the socioeconomically poor countries like ours, where these devices will be the frontliners for us to improve the care without making any excuses then?
It's a very problematic issue. In my country, we are dealing with in my country, we have a population of Bedouin Arabs. First of all, and we have the Jewish community. The Bedouin Arab has lower compliance. It's not a matter of, in my opinion, it's not a matter of money or the non-invasive thing. It's mostly a matter of compliance, because sometimes without money you can come in closer. To check glucose, it's nothing. To check glucose, it's not expensive. But if we are dealing with this population, it's very difficult for us, because It's low compliance. They don't come to the appointments. They don't apply our dietary restrictions. They have the kind of bread, the pita. It's like they don't believe you.
Yeah.
So in my country, it's more than we bring Arabic doctors, and we bring the Arabic nurse and Arabic dietitians, and those are the issues, because the major thing is to keep the glucose level low, and to measure the glucose level, you don't need to have you can just go to the clinic near your house and measure it with your fingers. It's more, for us, it's more a cultural and more adherent issue, more than the costly issues that indeed cost money and indeed are better, undoubtedly. And if you need to have a pump, by the way, in Israel, the pumps and everything, all the services are free. It's a socialized medicine. And yet we have burdens, and yet we have issues, and yet we still have a lot of work because of, if they don't believe you completely, if they're not into it completely, then it's a very problematic issue.
Yeah, because we recognize the, the value of the kind of information that you have produced by such a robust research that, it's slowly sinking into our own minds that this is indeed something of a wonderful opportunity where we can get a handle on it. There is a new thought process with some thought leaders within our country, which has really put us into a dilemma in the recent past. Professor Sheshaya, who is considered the father of the gestational diabetes mellitus in our country, who brought in the non-fasting test, which is, again, a bit of plus minus, but if that's the best thing we can do in our country, so be it, is what we are thinking. So the new thought process which has come up in his mind, and he's percolating it to the others as well, saying that by 11 or 12 weeks, the beta cells in the pancreas of the baby starts responding to the glycemic levels of the mother. Okay, that is where the entire process of the pathology begins. So the new suggestion, which we don't want to confuse the rest of the obstetrician till we do some studies and are clear about what we are talking, they said by 8 or 9 weeks you do the challenge test, and even if it is just slightly higher, you start very strict diet and exercises and start giving the metformin, because that's allowed in the early trimester of pregnancy. Get the sugars, really into a sub optimal level of, even if it's okay if she maintains the 120 milligram, but get it down to 110, tune it further, so that at that point in time, the fetal cells escape even a mild hyperglycemia, which may have long-term consequences. So that is the new thought, which we are not sure whether it is also ethical to, get the sugar so low in the early part of the pregnancy. What is your opinion?
I think it's smart. In Israel, we do the screening, the GDM screening, we do it 24, 28 weeks, like in the United States. But I do it, and I see more and more doctors that are screening. We have a complete list of screening tests, blood tests for the first trimester, where the patient just know that she's pregnant. We do the cytomegalovirus, we do VDRL, blood type, and the antibodies, complete blood count. We do toxoplasma. We do and I'm doing, sugar, as well as other doctors, hemoglobin A1C. I mean, we do blood glucose level to all our patients. This is common. This is part of the practice, to do a starving glucose level. And if the glucose level are elevated, we start with something. In those patients, we start a careful follow-up. I combine it with hemoglobin A1C as well, because it showed me not only this period, it showed me like a few weeks before. And it's not me. I didn't invent it. We do it. I see more and more doctors that are doing it, because in Israel, the routine test is glucose, fasting glucose in the beginning of pregnancy. But in my opinion, the combination of glucose and hemoglobin A1C is more valuable. So I agree. I mean, it's something interesting. It's something, yes,
Because, the earlier and earlier you catch it, because sometimes, there's a lot of conflict between what is the, use of having such strict glycemic levels throughout pregnancy when these consequences are anyway going to happen. Can you get a handle on that a little bit more earlier? So that is the thought process which is going on, especially because in our country, there are more than 5 million gestational diabetes mellitus every single year, which means that these are adding on to a huge population for a long-term care, which will be a huge burden on our health system as it is. So I think this has really given a lot of food for thought, and all the delegates are appreciating the content of your talk, which has triggered off their thought process in a much more serious way. So I think we will help to move the needle further. Thanks to you, EL. Bharti, Dr. Rita Singh and Sheetal Joshi are from Team Artist. If they want to raise any last 2 minutes with EL.
It was actually a very good talk, sir. We got a lot of information about the long-term consequences. And basically in our country also, the main challenge we feel is the follow-up. If we are able to do it effectively, I feel we'll be able to catch in the problems. So we have to find out ways for follow-up, not only for the mother, but also for the child. Yeah. So I don't know whether we have a scheme of kind of mother and the obstetricians and the pediatricians coming together so that we can hold on to such babies who are likely to have problems later on.
Thanks, Rita. Sheetal, anything?
It was really excellent research work which I've seen, and the publication, it really, it was good. In fact, it was, even we want to work on it, perhaps because India has lots of data and we are going to get lots of GDM if we go and follow up. So that's an excellent thing which I could learn from this presentation of yours, more than the other things. The publication and the research work was too excellent. It was
yeah. So thank you so much once again. Bharti, your closing.
Yeah, thank you. Words could not express our gratitude, but as a formality, Dr. Eyal, we are extremely thankful to you from the Kasoga and the KCOG College for your valuable time and valuable inputs. And as Sheetal said, this mind-boggling study, which puts our thought in our mind as why are we not even making a little more effort to collate all our data and try to analyze that and put it forward for the betterment of our women. We thank you very much for the time you've spent with us and shared all your studies with us. Dr. Eyal, we invite you again and again to India. I totally agree. India is an excellent country with violent vibrations. Please do come, and my personal request, do visit us in Hassan. Dr. Hema will tell you we are just about 2 hours or 3 hours from Hema's place in Bangalore. I extend a warm welcome to you. Whenever you visit Hassan, we'd be delighted to have you with us. Thank you very much for your time.
And one last thing, Eyal, we in a short while will brainstorm within our own organization that our state, which has the first of the kind of college within the state, we would perhaps get back in touch with you to seek you as an advisory and a mentor to some of the work that we may plan to do in many huge public institutions which have 10 times more the delivery rate all put together. So if we can have some trending or the sense of direction, it may be the new beginnings of a new era of understanding our own population better. So with that, once again, a really heartfelt thank you. Thank you very, very much. We'll see you again soon. Thank you.
See you again. Thank you and good night.
Thank
Goodbye.
You, Thank you.